Welcome back to the deep dive. Today, we're tackling a really core topic, something you see constantly in med-surg nursing: pain assessment and management.
Absolutely. It's fundamental stuff.
Yeah, source material is pretty dense, it's essential knowledge. So our aim here is to give you a clear, structured way through the main ideas, the safety points, and the management techniques you need for good practice.
That's so critical. The sources are very clear. Pain is actually the #1 reason people seek medical care anywhere in the world.
Wow, number one.
Yes. And if we don't manage it well, the impact is huge.
Hmm.
Unrelieved pain really diminishes a person's quality of life more than basically any other
Yeah.
single health issue. It's not just about feeling bad. It affects everything they do.
It's a functional crisis, as you put it. Okay, so the priority concept is obviously pain, and you can see how it immediately connects to comfort, cognition, sensory perception. They're all tied together. But before we jump into treatment complexities, we have to start with how we even define pain in the clinic. There's a universally accepted role, right?
There is. The sort of academic definition is that unpleasant sensory and emotional experience linked to tissue damage, actual or potential. But clinically, the gold standard, the one we live by, comes from McCaffrey.
Okay, what's McCaffrey's take?
Simply put, pain is whatever the experiencing person says it is, and it exists whenever they say it exists.
Wow. So that first lesson is profound. It's radically subjective. If your patient says they hurt, your job starts with believing them and acting.
Exactly. Self-report. That's always the most reliable indication of pain.
Okay, so if we believe the report, how do we start organizing our thinking about it? What are the main categories?
Well, the first big split is based on duration. So we talk about acute pain. This is the short-lived kind, from an injury, surgery, maybe acute inflammation.
And this type often serves a purpose, right? Like a warning signal.
Precisely. It's biology's alarm system. And classically, when that alarm goes off, you often see the sympathetic nervous system kick in.
Ah, the fight or flight response. Increased heart rate, blood pressure up, maybe sweating.
Right. But here's a really, really crucial point for practice, something you absolutely have to remember.
Okay.
The body adapts incredibly quickly. So just because you don't see those classic vital sign changes, it does not mean the patient isn't in pain. You just can't hang your hat on vital signs to prove or disprove pain.
That's a huge takeaway. Don't rely on vitals alone.
Never. And another critical point about acute pain, if it's managed poorly, especially like post-op pain, there's a really high risk it can turn into chronic pain. We call that process chronification.
Okay, so that leads us to the other side of the duration coin: persistent pain or chronic pain. How is that defined?
That's pain that lasts or keeps coming back for generally more than 3 months. And unlike acute pain, this type serves no useful biological purpose.
And because it's been going on so long, the body's adapted differently.
Exactly. You might even see vital signs that are lower than normal. The real danger with chronic pain is how it messes with daily life activities of daily living, relationships, work, just overall quality of life. Think about someone with really bad osteoarthritis, that kind of persistent non-cancer pain.
And the sources mention specific groups who are at higher risk for their pain not being treated adequately.
Yes, definitely. Older adults often get overlooked. Sometimes they think pain is just a normal part of getting old, which it isn't. Also, patients with a substance use disorder, or SUD, face stigma and challenges. And anyone with a language barrier.
The sources also specifically call out American veterans.
That's right, it's a significant issue. Over half of recent combat veterans report persistent pain. It's often linked to musculoskeletal problems, trauma injuries, and frequently co-occurs with PTSD.
That connection between persistent pain and trauma, especially PTSD, that feels like a good bridge to talking about the mechanism of pain, right? Because maybe it's not just about damaged tissue anymore.
Exactly. It often involves changes in the nerve pathways themselves. So let's pivot to mechanism. We generally talk about nociceptive versus neuropathic pain.
Okay. And understanding this is key for multimodal analgesia, right? Using different drugs to hit different pathways.
Precisely. If we're going to target different mechanisms, we need to know what they are. Let's start with the normal type, nociceptive pain. This is your typical pain from actual or potential tissue damage. Think somatic pain from skin or muscle, or visceral pain from organs.
And there are 4 steps involved in this normal process: nociception. The sources mention a figure 5.1 showing this. How does that work?
Right. Those 4 steps are what our drugs often target. First is transduction. That's the very start, where the injury happens. Noxious stimuli trigger nerve endings, called nociceptors, and chemicals like prostaglandins and serotonin get released.
Okay, step 1, the trigger. Then what?
Step 2 is transmission. The electrical signal generated at the nerve ending travels up the nerve fibers toward the spinal cord and brain. This happens along two main types of fibers. A delta fibers, which are fast and carry sharp, localized pain signals, like when you touch something hot and pull back fast.
That protective reflex.
Exactly. And then there are C fibers. These are slower, and they carry the signals for dull, aching, burning, more poorly localized pain that tends to linger.
Got it. Transduction, transmission. What's next?
Step 3 is perception. This is when the signal reaches the higher brain centers and you become consciously aware of the pain. It's not just a signal anymore, it's an experience.
Instantly.
Step 4 is modulation. This is fascinating. It's the body's own pain control system. Descending pathways from the brain release substances like endogenous opioids are natural endorphins plus neurotransmitters like serotonin and norepinephrine. These act like brakes to dampen the pain signal transmission.
So the body tries to regulate itself. Okay, that's nociceptive. What about the other type? The one you mentioned might be linked to trauma or conditions like diabetic neuropathy?
That's neuropathic pain.
Yeah.
And this is different. It's not caused by ongoing tissue damage in the same way. It's sustained by damage or dysfunction within the peripheral or central nervous system itself. The wiring is faulty, essentially.
And that makes it harder to treat.
Notoriously difficult, yes. And patients often use very specific words to describe it. If you hear things like burning, shooting, tingling, electrical, or pins and needles, that should make you strongly suspect a neuropathic component is involved.
All right, let's move into assessment. We know self-report is key, and the nurse's role starts with advocacy, believing the patient. How do we build on that belief with a solid, comprehensive assessment?
It's foundational. You need a thorough pain assessment when the patient is admitted, obviously, but also with every new report of pain, before and after you give pain medication, and anytime there's a significant change in their condition or treatment plan.
So it's ongoing. What key areas do we need to cover in that assessment?
There are four main components. First, location. Where does it hurt? Is it localized to one spot? Does it radiate or spread? Is it referred pain, felt somewhere distant from the actual injury? Using a body diagram can be really helpful here. Some tools like the McGill-Melzack Pain Questionnaire include one.
Okay, location. What's second?
Intensity. How bad is the pain? This is where we absolutely need reliable and valid self-report tools. And the critical instruction here, the thing you must do, is use the same scale consistently with that patient over time. You can't switch between scales day to day. You won't be able to track changes effectively.
Makes sense. What are the common scales we use?
The most common is probably the numeric rating scale, NRS, the 0 to 10 scale, where 0 is no pain and 10 is the worst imaginable pain. It usually has anchors, like defining what moderate pain means on that scale.
Right, 0 to 10. What if someone struggles with numbers, kids, or maybe someone with cognitive issues?
That's where the Wong-Baker Faces Pain Rating Scale comes in. It uses 6 cartoon faces, showing expressions from smiling, no hurt, to crying, hurts worst. They're numbered 0, 2, 4, 6, 8, 10 to correspond roughly with the NRS.
Ah, the FACES scale. I remember seeing that.
Yes, but here's a vital point about the FACES scale. It is still a self-report tool. The patient chooses the face that best shows how they feel inside. The clinician should never try to match the patient's actual facial expression to one of the cartoon faces. That defeats the purpose.
Good clarification. So, location, intensity. What's third?
Third is quality. What does the pain feel like? Ask the patient to describe it in their own words. Is it sharp, dull, aching, throbbing, cramping? And remember, if they use those neuropathic descriptors, burning, shooting, tingling, that's a red flag.
Okay. And the fourth component?
This one's really important for planning care. Setting comfort function outcomes. We need to work with the patient to set realistic goals.
What does that look like in practice?
Well, for someone who just had major abdominal surgery, maybe a pain score of 0 isn't realistic in the first 24 hours. But perhaps a goal of 2 or 3 out of 10 is achievable. And importantly, that level allows them to take deep breaths, cough effectively, maybe even get out of bed to a chair. The goal connects pain relief directly to improving their function.
That makes so much sense, linking relief to what the patient needs to do for recovery. Okay, but what about the really tough situations? The patient who can't self-report. You mentioned cognitively impaired patients, people on ventilators, maybe very stoic older adults. They're at the highest risk, right?
They absolutely are. They're often undertreated. For these situations, we rely on the hierarchy of pain measures. It's a structured approach outlined in the source material, often shown in a table like Table 5.6.
Okay, walk us through that hierarchy. What's step 1?
Step 1 is always attempt to get a self-report. Even if someone is nonverbal, can they point? Can they nod or shake their head to simple yes-no questions asked in the present tense, like, are you hurting right now? Use pictures, simple language, whatever might work. Don't assume they can't communicate anything.
Okay, always try first, if that fails.
Step 2 is a really useful clinical guideline. Assume pain is present, APP. If the patient has a condition or has undergone a procedure that is known to be painful, like a bone fracture, major surgery, burns that, you should assume pain is present until you have evidence otherwise. Start treating it preemptively.
That feels like safe practice. Assume pain if the situation warrants it. What's step 3?
Step 3 involves observing behavioral signs. Look for things like facial expressions, grimacing, wincing, body movements, restlessness, guarding, rigidity, vocalizations, crying, moaning, groaning. Sometimes a patient has their own unique way of showing pain, their pain signature. You learn to recognize it.
Are there specific tools for documenting these behaviors?
Yes, there are validated tools like the PACSL-2, pain assessment checklist for seniors with limited ability to communicate, or the Pain and IFUS pain assessment in advanced dementia. These help quantify the observations.
But how does a score on one of those tools relate to the 0-10 scale?
That's the critical distinction. A behavioral score tells you if pain is likely present, and it can help you see if your intervention worked. Did the behaviors decrease? And this is vital, that score is not the same as a pain intensity rating from the patient. You know, pain is there, but you don't truly know how bad it is from behaviors alone. The intensity remains unknown.
Okay, that's crucial. Behavioral score indicates presence, not intensity.
Right.
What are the final steps in the hierarchy if needed?
The last steps are evaluating physiologic indicators like vital signs, which we already said are unreliable, and then potentially conducting an analgesic trial. Carefully giving a dose of pain medication and observing if the problematic behaviors lessen.
Okay, let's switch gears to managing the pain. Once we've assessed it, what are the core principles for using medications?
There are really two main goals with drug therapy. First, prevent pain whenever possible, rather than just chasing it after it gets bad. Second, maintain a level of pain control that allows the patient to function adequately.
And how do we achieve that with dosing schedules?
We differentiate between around-the-clock ATC dosing and PRN, as needed dosing. ATC is for pain that's expected to be present continuously, or for more than, say, 12 hours out of 24. Think post-op pain in the first day or two, or chronic cancer pain. PRN is for intermittent pain, or for breakthrough pain that occurs despite the ATC regimen.
And the overall strategy often involves more than just one drug, right?
Absolutely. The gold standard approach now is multimodal analgesia. This means using 2 or more different classes of pain medications that work by different mechanisms.
Like combining a non-opioid with an opioid.
Exactly. Or adding an adjuvant medication. The big advantage is that you can often get better pain relief with lower doses of each individual drug, which usually means fewer side effects overall. It's about attacking the pain from multiple angles.
Makes sense. Let's break down the main analgesic groups, starting with the non-opioids. What falls into this category?
Primarily, we're talking about acetaminophen Tylenol and the nonsteroidal anti-inflammatory drugs, or NSAIDs, like ibuprofen or naproxen.
Okay, tell us about acetaminophen first. How does it work? What are the risks?
Acetaminophen works mainly in the central nervous system. It reduces pain and fever, but, and this is important, it has no significant anti-inflammatory action. The major safety concern with acetaminophen is hepatotoxicity, or liver damage, especially with overdose. So dose limits are critical. On the plus side, it generally has few gastrointestinal side effects.
Got it. No anti-inflammatory action. Watch the liver dose. How about NSAIDs?
NSAIDs work differently. They inhibit enzymes called COX, which reduces the production of prostaglandins. Prostaglandins are key mediators of inflammation, pain, and fever. So unlike acetaminophen, NSAIDs do have significant anti-inflammatory effects.
But they come with their own set of risks.
They do. The big ones are GI toxicity, irritation, ulcers, bleeding, because prostaglandins also protect the stomach lining. They can also affect platelet function, increasing bleeding risk. There are cardiovascular risks associated with some NSAIDs, and they can affect kidney function, especially if the patient is dehydrated.
So with NSAIDs, the rule is
use the lowest effective dose for the shortest possible duration, and ensure the patient stays well hydrated to protect those kidneys.
okay, non-opioids covered. Let's move to the heavy hitters. Opioid analgesics. These are still the cornerstone for what kind of pain?
They remain the mainstay for managing moderate to severe nociceptive pain. Think post-surgical pain, cancer pain, severe trauma pain.
How are opioids classified?
The main group we use for severe pain are the pure agonists, like morphine, hydromorphone, fentanyl, oxycodone. These bind to mu-opioid receptors and activate them fully. A key feature is that they generally don't have a ceiling effect on analgesia. Increasing the dose usually increases the pain relief, though side effects also increase.
Dosing seems critical here. How do we approach that?
Very carefully with titration. That means adjusting the dose based on the patient's response, balancing pain relief against side effects. Especially in older adults, the mantra is start low, go slow. You often begin with the dose that's maybe 25% to 50% lower than for a younger adult.
And nurses often work with dose range orders, right?
Yes, range orders like morphine 2-4 milligram IV every 3 hours PRN give the nurse flexibility and require good clinical judgment to choose the right dose within that range based on the current assessment. Box 5.1 in the source likely details this.
Now, formulations are really important from a safety perspective. Can you explain the difference between short-acting and long-acting opioids?
Absolutely critical. You have short-acting or immediate-release IR opioids. These typically start working in about 30 minutes when taken orally and last a few hours. Then you have modified-release opioids. These might be labeled ER, extended release, SR, sustained release, CR, controlled release, or LA, long-acting. They are designed to release the medication slowly over many hours, providing prolonged pain relief.
And the huge safety warning here is...
Never crush, break, or chew modified-release opioid tablets or capsules. Doing so destroys the slow-release mechanism. The entire dose gets absorbed rapidly, all at once. This can cause a massive overdose, leading to profound respiratory depression and potentially death. It cannot be stressed enough.
Understood. Do not crush those long-acting pills. Can you compare a couple of the common pure agonists, like morphine and fentanyl?
Sure. Morphine is kind of the classic standard opioid. It's hydrophilic, meaning it likes water, so it tends to have a slightly slower onset of action but a longer duration. Fentanyl, on the other hand, is highly lipophilic. It loves fat. This means it crosses into the brain very quickly, giving it a very fast onset, but its duration of action is shorter.
When might you prefer fentanyl?
Fentanyl is often preferred when you need very rapid analgesia, or in patients who have kidney or liver failure, since its metabolism is different, or if someone is hemodynamically unstable.
And fentanyl also comes as a patch, right? Any special safety points there?
Yes, the transdermal fentanyl patch. Another critical safety rule. Do not apply heat over the patch. No heating pads, hot tubs, electric blankets. Heat dramatically increases the absorption of fentanyl through the skin, which again can lead to dangerous overdose and respiratory depression.
Okay, no heat on fentanyl patches. Now, we can't talk about opioids without acknowledging the opioid epidemic, the issue of opioid use disorder, OUD. How do nurses navigate this complex situation?
It's incredibly challenging. Nurses are caught in this ethical balance. We have a clear duty to relieve pain and suffering, but also a duty to avoid causing harm, including contributing to addiction or managing pain safely in someone who already has OUD.
The source material probably has guidance for patients with OUD, maybe table 5.7.
Yes, there are specific considerations. It requires careful assessment, often collaborating with addiction specialists. For instance, managing acute pain in someone on maintenance therapy like methadone or buprenorphine needs specific planning. And if a patient is on a naltrexone, which is an opioid antagonist used for OUD treatment, controlling their acute pain can be extremely difficult. They might need 10 to 20 times the usual opioid dose to overcome the blockade. Close collaboration is essential.
Wow, that's a huge difference. Let's talk about the side effects of opioids that all patients might experience. What's the most common one?
By far, the most common side effect is constipation. And importantly, tolerance usually does not develop to this side effect. Patients don't get used to it. So if someone is starting on regular opioids, you absolutely must start a prophylactic bowel regimen, typically a stool softener plus a stimulant laxative right away. Don't wait for the problem to start.
Okay, anticipate and prevent constipation. What about the more serious side effects?
Nausea and vomiting can happen, but tolerance often develops quickly. The most feared side effect, though, is respiratory depression. But crucially, significant respiratory depression is almost always preceded by increasing sedation.
Ah, so sedation is the early warning sign we need to catch. How do we monitor that systematically?
We use a standardized tool, the Passero Opioid-Induced Sedation Scale, or POSS. This is probably one of the most high-stakes assessment tools you'll use regularly. Table 5.9 likely shows it. It grades sedation levels.
Okay, take us through the critical action points on the POSS scale.
Level 1 is awake and alert. Level 2 is slightly drowsy but easily aroused, usually acceptable. But if the patient reaches POSS level 3, frequently drowsy, drifts off during conversation, but still arousable, that's your immediate trigger point. You need to decrease the opioid dose, typically by 25% to 50%, and monitor them very closely. Don't wait.
Intervene at level 3. What about level 4?
Level 4 is somnolent, Minimal or no response to verbal or physical stimulation. This is an emergency. You must stop the opioid immediately, try to arouse the patient, call for help, like the rapid response team, and prepare to administer the opioid antagonist, naloxone, Narcan.
Okay, stop opioid, call for help, consider naloxone at level 4. Any other respiratory warning signs?
Yes, snoring. Particularly new or loud snoring in a patient receiving opioids can indicate upper airway obstruction due to muscle relaxation and sedation. It's an ominous sign that can precede respiratory arrest. Pay attention to snoring.
Good point. And if you do need to give naloxone for significant respiratory depression, say, the respiratory rate is less than 8 per minute and shallow, how should you administer it?
The key is to give it slowly, titrating it carefully. The goal is just to reverse the respiratory depression and excessive sedation, not to completely reverse all the pain relief.
Yeah.
If you give it too fast or too much, the patient can experience sudden, severe withdrawal pain, agitation, and potentially dangerous cardiac effects like arrhythmias. Slow titration is safer.
All right, beyond medications, what about non-pharmacologic approaches? Are they just nice extras, or do they play a real role?
They play a very real and important complementary role. They should never be seen as a substitute for needed analgesics, especially for moderate to severe pain. But they can reduce anxiety, decrease stress, give the patient a sense of control, and sometimes even reduce the amount of medication needed.
What are the main categories of these methods?
We can group them into physical methods and cognitive behavioral methods.
Yeah.
Physical modalities often involve cutaneous stimulation stimulating the skin. This includes applying heat, which is often good for muscle stiffness, like in osteoarthritis, and cold, cryotherapy, which is better for reducing inflammation and swelling, especially with acute injuries like sprains.
Heat for stiffness, cold for swelling. What else?
Another physical method is TNS, which stands for transcutaneous electrical nerve stimulation. It involves placing electrodes on the skin, over or near the painful area, and delivering small electrical currents. This typically produces a buzzing or tingling sensation that can interfere with pain signal transmission, sort of like closing the pain gate.
Okay, TNS units. What about the mind-body approaches, the cognitive behavioral ones?
These work by shifting the patient's focus away from the pain and promoting relaxation. Simple distraction is surprisingly effective engaging the patient in conversation, watching TV, reading, listening to music. Studies show distracted patients often request less pain medication.
Simple but effective. What are some more structured techniques?
Imagery, or guided imagery, involves coaching the patient to visualize a pleasant scene, feeling, or event. It requires concentration, so the patient's pain needs to be reasonably well controlled for it to work well. Then there are various relaxation techniques, deep breathing exercises, progressive muscle relaxation, meditation, even things like providing a gentle massage, if appropriate for the condition, ensuring comfortable positioning, using humor, and playing calming music can all help reduce the perception of pain.
So a whole toolbox of non-drug approaches to use alongside medication. Now, before we wrap up management, there's a really important ethical point the sources always cover: the use of placebos.
Yes, this is non-negotiable. A placebo is an inactive substance or procedure given to a patient. Any effect it has comes from the patient's expectation or the context, not from any inherent chemical activity.
And the ethical stance on using them deceitfully in clinical practices.
It is absolutely never appropriate. Using a placebo without the patient's fully informed consent is deceptive, it violates their autonomy, and it completely undermines the trust that is essential to the nurse-patient relationship.
So if a nurse receives an order to administer a placebo for pain,
They have an ethical and professional obligation to refuse that order and to immediately contact their nursing supervisor or manager to address the situation. You do not give deceptive placebos, period.
crystal clear. Okay, finally, as the patient prepares to leave the hospital or transition to another level of care, what's crucial for managing their pain effectively after discharge?
Care coordination is key. This involves collaborating closely with the whole interprofessional team: doctors, pharmacists, physical therapists, social workers. Before the patient goes home, you need to ensure they have adequate prescriptions for their pain medications, maybe referrals for ongoing therapies.
And patient education is vital, right?
Yeah, absolutely critical. The patient and their family need clear, understandable instructions on how to take their medications, the dose, the timing, what to do for side effects. They need to know warning signs to watch for. And if they're going home with more complex therapies, like a home infusion pump for pain meds or maybe a continuous peripheral nerve block catheter, sometimes called PCRA, they need thorough teaching and demonstrated competency on how to manage it safely at home. Home safety is paramount. #tag outro, Rafa.
Okay, that brings us to the end of this deep dive. Let's quickly recap the absolute essentials you need to take away.
I'd say number one, pain is what the patient says it is. Believe the self-report. Number two, multimodal analgesia is the standard of care attack pain from different angles.
Right. And number three, vigilance for opioid side effects, especially watching for sedation using the POSS scale before it escalates to respiratory depression.
Exactly. Catch sedation early. And number four, use the right assessment tools for the situation, the NRS, FACES, the hierarchy for nonverbal patients. Don't forget the comfort function goal setting.
Perfect summary. Any final thought for our listeners?
Just that pain management is a continuous process, an ongoing responsibility. Our ultimate goal is always to help patients function better and improve their quality of life. Embrace that ethical and professional duty to manage pain effectively and compassionately for every patient, setting aside any personal biases. It's fundamental to good nursing.
A powerful reminder. That really covers the core of this vital topic. Thanks so much for walking us through that. And thank you all for joining us on the deep dive. We'll see you next time.